why don't we get started? So I want to welcome everyone, our organizers, our panelists. Thanks so much for being here, and everyone who's tuning in to the UCGIS Symposium. My name is Jeremy Menace, and I'm president of UCGIS this particular year, University Consortium for Geographic Information Science, and I'm also a professor at Temple University. This is actually the first session for the whole symposium, so I'm really excited to kick this off with a great set of panelists and a really interesting session. I want to introduce first my co-organizer for this particular session, who is Wei Luo, who's an assistant professor in geography at National University of Singapore. Hello, Wei.
Yes. Yeah, thanks for the introduction. So yeah, I think it's good.
And so at this point, I'm actually going to turn it over to Wei, and Wei is going to introduce our panelists for us.
Sure. Yeah. It's my pleasure to introduce the four top scientists, whose expertise in the intersection of geography and public health. So the first one is Ruiyun Li, who is a researcher from the Center for Ecological and Evolutionary Synthesis and the University of Oslo and Norway. And I just want to highlight one of his publications on COVID-19 in the Science magazine has been awarded as a highly cited paper in Essential Science Indicator, I think already with more than 2,500 citations. And the second panelist is Shengjie Lai, and who is a senior research fellow and from geography and environmental science at the University of Southampton and the UK. He has at least 10 high-profile publications on the COVID-19, including like Nature Science, Nature Medicine, Nature Human Behavior, and Nature Communications. Looks like all have natures, but one just a science. And so the third one is Elizabeth Root, who is a professor from Geography Department at Ohio State University, and her research focused on the spatial statistics method and GIS, and she integrated the social economic and environmental context into the studies of disease process and human behaviors. And our last panelist is Paul Delamater, and who is assistant professor at the Geography Department at the University of North Carolina, US, and his recent research has focused on the understanding the childhood vaccination and herd immunity and the vaccine preventable diseases in the US. And I also noticed he has several publications on this topic and the COVID. So yeah, I don't want to spend too much time, and I would like to turn the turn that session to all of our panelists to give us like a 5 minutes introduction about themselves and their research and on the COVID and all the please. And so maybe we just follow the order based on what maybe I just introduced. How about that? So yeah. How about the Ruiyun Li? You can give the first. How about that?
Yeah, thank you. Well, so let me try and find my slides. And yeah.
So there's a button. It's the second one from the right. It should have it's like a little screen with a red slash through it. And if you hit that, it'll allow you to share your screen.
Happy to give it a try if nobody cares. Is that okay? Okay, I'm going to share my screen.
There's no orders. No specific orders.
All right, do we see something?
Yes, we do.
Oh, yes. All right, so I'll start. And what I wanted to just briefly talk about today is sort of thinking about how we can identify inequalities and really what's missing or what's possible with the geographic and GIS data that we have right now. So Early in the epidemic, there was a group of lawmakers in the United States that actually called on the federal government to change how they were collecting data. They actually approached the Health and Human Services Secretary and said that it's critical for the federal government to make a concerted effort to account for existing racial disparities in health access and how these persistent inequalities may actually exacerbate the disparities in COVID in the weeks and months to come. This served to be completely true, and they urged HHS to work with the states and localities and all the private labs that were collecting data to get better data basically on health disparities. And for me, I'd like to point out sort of 2 points in response to this. The first is that we do not set out to collect information which will help us understand inequalities and the causes and consequences of them from day one. We are actually perpetuating these inequalities in our response to the pandemic. And the second point that I would make is that inequalities encompass more than just race and ethnicity, although that's been the focus, a lot of the dialogue in the United States. And so we need to integrate data from many different sources to truly address the root causes of inequality in the pandemic. So let's start with race and ethnicity as an example. We know that across the country, deaths due to COVID-19 are disproportionately high among African Americans, Native American populations, and Hispanics, compared with the white population. And part of the disproportionate impact of COVID-19 is on communities of color has been structural factors that prevent them from social distancing in the best of their abilities. Minority populations in the US are disproportionately making up essential workers. And early in the pandemic, this was really a driver of a lot of spread in these communities. Another driver of inequality, though, is lower levels of access to healthcare and structural and social barriers about getting timely testing and care for COVID. But these data actually mask a significant problem, which is systematic across the United States. And in some states, race is fairly well reported on all of the COVID records. My own state of Ohio does a fairly good job. About 10% of our records are currently missing race information. But there are some states with more than 50% of their COVID records in their surveillance system that don't actually report a race at all. The geographic differences we see in COVID-19 case rates really reflect a combination of both area-level epidemiologic and population-level factors. Some of the geography of COVID is directly related to the timing of COVID-19 introductions and the subsequent community mitigation measures. So early introductions in New York, Chicago, Detroit, these cities were really unprepared. And so the virus took a really heavy toll there in day one. But the story of COVID's geography is much more complex now. And we see population level inequalities and social determinants of health affecting the spread of the disease more so than the early introduction phase. And given the lack of data that explicitly collected to understand inequalities of COVID, I think we need to use geography to understand and respond to the inequalities we see today. And this is one of the ideas that was actually proposed way back in the late 1990s by the Public Health Disparities Geocoding Project. The field of geography, of course, has a myriad of tools that help us understand spatial inequalities and health outcomes. And geographical theory helps us investigate and explore the social and structural drivers of these spatial inequalities. So we can look at data at multiple levels of geography to explore these drivers. We can look for hotspots, we can overlay data. Space really allows us to triangulate multiple data streams and pull together other population level data that can help inform policy and decision making. In the absence of person-specific data on the social, economic, health, and structural factors that impact COVID disease, which we really don't have right now, except in very small areas, we could and we should use geography to explore these inequalities and inform our health policy. So an example of this from my own work is stuff that I've done with the Ohio Departments of Health and Medicaid that I was working with throughout the early phases of the pandemic. So what you see here is something called the Ohio Vulnerability Index. It's a composite area-based measurement of neighborhood socioeconomic inequality. It's based on things like the CDC's Social Vulnerability Index and other things like New Zealand's Deprivation Index or the Scottish Deprivation Index. And it highlights disadvantage in the rural Appalachia and the urban cores of our city in Ohio. And the red, of course, outlines areas that are that have some of the highest COVID rates in the state. And so the state asks questions of how can we use these data? How can we use them to address inequalities in testing and target testing, but also target vaccination, since we know these areas are systematically underserved. What I see as the biggest barrier to this type of work is that our public health surveillance systems were simply not designed to integrate data from multiple sources. It's an intelligence problem as well as a data science problem. We're collecting a lot of COVID data at this point, but without a comprehensive method for ingesting the data, critically evaluating it, critiquing it, finding gaps and delays, and creating intelligence from it, it won't provide us with the information that we need to combat this public health crisis. This is a schematic of a system that does this, and it's what we actually proposed for the state of Ohio. It piggybacks on models that have been used by the WHO and the CDC for decades. But we can ingest data from multiple knowledge and data sources, both qualitative and quantitative, and convene a team of experts to sort of change this data into intelligence for our policymakers. And geography actually plays a really critical role in merging and interpreting spatial patterns of spread. And that's because COVID-19 is really, any sort of infectious disease is by its very nature spatial because of properties of diffusion and contagion. And so adding in that geographic component where we can sort of look at the geography of the disease is critical in our understanding and our surveillance of the problem. So basically, to take a step back, I would say that COVID really has allowed us to really examine structural, social, and economic inequalities that both led to the emergence of the disease, but also has exacerbated risk and spatial patterns of the disease. In order to address these inequalities, we need to intentionally collect data that help us to combat inequalities. And we need to create intelligent data systems that triangulate and merge this, and really harness the power of geography in that to understand these drivers of sociospatial inequalities. So I will leave it at that and sort of hand it off to the next person. I assume I stopped sharing my screen. Ah, I did it. Yay, okay. I shouldn't be so surprised, but thank you, Paul. I appreciate that.
Thanks, Elizabeth. Rayan, would you like to try again?
Sure. How about Riyun? Do you want to try? Give another shot. Otherwise, yeah, I can maybe share the screen for her because she already sent her PowerPoint to me. So, hi, Riyun, are you here? Yeah, I'm not. Yeah, if Riyun is not here, so maybe Shengjie.
Okay, maybe I can go first.
Yeah. Yeah.
Let me share my screen. Can you see my screen? Yep.
Yep.
Cool. Okay, nice. Okay, thank you for inviting me to present my work today. I'm a senior research fellow at the WOPOP of the University of Southampton. And the WOPOP research group aims to provide the openly available spatial demographic data for socio-economic development and health promotion, particularly in the low and middle income countries. And today my topic will be around marrying human mobility, COVID spread risk, and intervention effectiveness. Some background about me. I have been long engaged in the research focusing on the human mobility and infectious disease transmission, particularly interested in the using normal data sources for the population, for measuring population mobility. And traditionally, we kind of have the three major methods for measuring human movements, like census, traffic survey, and travel history survey. But today, we have more and more new types of data sources, such as the statistics of the shipping of the flight passengers numbers or personal GPS trackers, and also the geolocation data derived from the mobile phone or apps locations. And these apps, such as the developed by the Google or Twitter or Facebook, are increasingly used in the populations. And these kinds of new data sources, data are being tested for understanding the travel patterns and providing quite a nice complementary data set to the traditional data sources. And recently in this pandemic, this data set has been widely used to understand the spread of the COVID. And I have been leading some kinds of these studies and to explore the use of this data. And if you are interested, you can find these our studies in the WOPOP web page, COVID-19 web page, and these pages include our new papers, reports, and blogs. And this study uses different quantitative analysis approaches and combining the epidemiological and demographic data to answer some kind of critical scientific question for understand the pandemic. And from the very early beginning of this pandemic, and such as at the early stage of this outbreak, I think the first and important question is how has the virus spread within China and it can be between the continents, and based on like mobile phone data we obtained, and also the international airline passengers travel data that we have did some kinds of preliminary analysis. Such as this one, we published a very early report about the spread risk of the virus within and beyond China by using the airline travel data and mobile phone data. This report has been published just 2 days after the Wuhan's lockdown. And I think the further question that everyone will ask, especially for new emerging pathogens, which non-pharmaceutical interventions had the biggest effect in containing the COVID-19, especially such as the last year in January, in February, and not too much evidence came out, and such as that's the travel registration or early case identification, isolation, and also the social distancing measures played a very, which one can play a big role in the in containing the pandemic. So based on some kind of epidemiological model and also mobility data, we have done some work, especially taking China as an example to look at the different kinds of the intervention on the containing this disease. And then another study we did is try to expand this study from China to globally, and we obtained the data from Google and also combined some data from China and together to look at the impact of the travel restriction and also the social distancing measures across 135 countries, and to explore their impact on the pandemic, the first wave of pandemic across the world. And I don't want to talk about into the details, but just briefly to look at some kinds of work we have done. And the third one is because in the very early stage of the pandemic, we want to know how does the coordination of the interventions can affect, improve the containment or to mitigate the COVID-19, and because even during the pandemic, both countries, all countries are dependent in one way or another on their neighbors, and we use the mobility data from Google and Vodafone in Europe, and to look at these kinds of the coordination efforts on the pandemic responses, and we found that in some countries they may play some countries may play more important roles on the resurgence of the risk of the resurgence on Europe, because they have a higher connectivity and with more people movement between the countries. So, and I think it's quite easy to understand. And another one is how, because now we have more vaccine rolled out, but before the herd immunity achieved through the vaccination, and how effectively we can combine the MPI and vaccination together to prevent another resurgence. So we take China as an example. We use a very high spatial resolution data to, not just spatial, but also the spatial and temporal resolution data to look at the how we can combine the vaccination also with the social distancing measure together to prevent another waivers. And here we based on the mobile phone data to develop the index called the social contact index to look at the different scenarios of on the intervention and also the potential resurgence together. And yeah, we know that the new variants have continuous threat on the efficacy of the vaccines and also maybe another waves of these pandemics. So we also use the Google data and Facebook data to look at the population international movements and to understand what's the international risk. Yes, just some of the preliminary analysis for this study. And also we look at the international travel patterns from India and what's the potential risk of the variant found in India might be spread from India to another countries. So yeah, and next step we are continuing looking at the population movement in the vaccination areas. In the vaccination area, and to understand what's the distribution of vulnerable population by combining the WPOPs, the population density maps. We already have quite a lot of the mapping works done for the global population distributions. So, and yeah, some work we are continuing to working on, and yeah, that's our works, and happy to answer the you are interested in our works. Thank you.
But as a backup, perhaps Paul go next.
Yeah, maybe let Paul go next, and then
and Wei, if you want to forward me the email, yep, and I can share for you.
Let me do
Sure.
that.
Okay, bye.
You guys see my desktop?
Yes.
Excellent. All right. Is everything still okay? I lost some of the stuff here. I need verbal confirmation.
We can see it.
Okay. I'm Paul. I'm from UNC at Chapel Hill, and I'm going to talk about my website, NC COVID, that I created during the pandemic. So it is definitely not a dashboard. It was driving me a little bit insane when people were calling it a dashboard at the beginning of this thing. It is a website. I worked on this during March, April, May of last year, and I launched it during June. I don't know if you can see, it's probably pretty small, but you can see this is my homepage on the first day that I put the site up, and you can see the pandemic had just gone about this far. We were in North Carolina. We were just about ready to hit one of our first peaks at the time. So I launched this website. This was a little different for me. I mostly did this out of frustration, to be honest. Back in March, when things were starting to kind of go off the rails, I was trying to get a hold of every single person I knew about working with them and about trying to basically help out society with pandemic response, and I was very frustrated with a lot of my fellow scientists because they were really focused on like writing grants and publications about COVID rather than like rapidly getting the information out. I felt that it was a little selfish, and I wanted to do something different. The other thing that I found was that the state governments that I was kind of working with and around were mostly providing what I thought was non-valuable information. A lot of times it was just lab-confirmed COVID cases or maps of overall case counts. And my biggest complaint about any of this was that I felt like I wasn't getting any useful information to help me understand my risk of contracting COVID in my place where I lived. And I feel like if I was struggling with that, then a lot of other people were as well, and maybe they weren't getting the type of information that would actually help them understand their risk. So what I did was I wanted to create this website and to provide like what's basically value-added information, all the skills I've gained over the years in GIS and spatial stats to really leverage those skills to take what was already available publicly and really, squeeze some more out of it and make it easy to digest for the public just to look and understand. I wanted to create something I could update very frequently. That was another thing that was driving me a little nuts, was that I felt like I wanted to see updates daily, so I wanted to make something that I could update daily without too much work. I was very fortunate to, right at the beginning of the pandemic, literally the Monday after we got sent home from the university on a Friday, I found out that my K award had been, and my K award, surprisingly, was about studying infectious diseases and herd immunity and vaccines. I had proposed to study measles, but I quickly pivoted to working with COVID. The other thing I wanted to do is develop my skills in data visualization. So now I'm going to move my thing over here. I'm just going to show you a little bit of the website. This is the homepage that is a lot different. This used to be a lot smaller. I have things like people actively infected, people who are infected and infectious, new people infected today and next week. I haven't updated it yet today. The North Carolina DHHS updates their info at about noon every day. And so I start my meat grinder going about then. And then again, here is my number of people actively infected who are infectious and non-infectious. I'll just show you, like, zip through some of the fun things I've done. I like the idea of creating a timeline so you can see during all of this, and it started again from a small little timeline to now this thing that has a lot of events. Everything I thought was like epidemiologically relevant happening at the time. You can see statewide mask mandate goes into effect and holidays and things like that. I'll show you some maps. One of the things that I first created that I was doing a better job, I thought, than the state of North Carolina was that I was just showing case rates by zip code over 2 weeks. I felt like that was a much better thing to understand for people than just what are cumulative case counts in places. And so I changed this up as it's gone on. I added this little graph that shows how the state as a whole has gone. And one of the other things I did was allowed you to click on things and, all the sorts of fun things that you can do now with maps. One of the other fun things I did was create trend maps. It's not very exciting now because it's been so flat in North Carolina. But each of these has a little pop-up graphic, and you can just click around the map and see places where things are getting increasing or decreasing or flat. I wanted to also show you some of the other things that I was thinking about with trying to present information to people in a way they could understand. So I found that Georgia Tech site that had been estimating event risk. And so I did that spatially. So it was like if you randomly selected 25 people who lived in any zip code and put them together in a room, what is the probability or percent chance that one of them is currently infectious right now? So you can still see some of these places in North Carolina. You take 25 people, put them in a room, it's like a 27% chance. I was just trying to think about other ways to get people to kind of understand the magnitude of the pandemic. So I did things like 1 out of every 123 people are currently infected in the zip code of Greenville, North Carolina right now. So it's basically running models and then mapping the results and really trying to provide useful information. Now that's changed from cases and understanding that, now vaccination. So now I have a whole suite of information about the pace of vaccination in North Carolina, and like how fast would we have to speed up to hit certain benchmarks, or when would we be done if we keep going at our current pace. I've also got some cool maps in a cool time series thing that I did that's all interactive. So if you grab this, you can see the percent of people with 1 dose or 2 doses are fully or at least partially vaccinated, I guess. And you can look at this over time. And then let's see, what was the last thing I wanted to show you? And then I've also moved into showing some of analysis, thinking about what Liz showed us with the social vulnerability. So I'm actually created a bivariate choropleth map. My first, again, learning data is my first foray into that to kind of show basically which places have like high vaccination uptake and low social vulnerability, and then places with like low uptake and high social vulnerability. And then we can map these and everything's clickable. So that's my website that I created during this pandemic. And all the processing I do in this is in R, and the whole website's built in R Markdown. It takes me about 25 to 30 minutes a day, give or take a little bit. I still have some manual data prep I have to do every day. And then I run my scripts, and then I regenerate the site, and it all just updates every day. And I've been literally doing that every day for more than a year. The state stopped providing weekend data on the weekend, so I at least have Saturdays and Sundays off now. So challenges have been data access. I think everyone that's been working with COVID data has probably run into this. North Carolina uses, you may see the awful glow of Tableau right down here. They use Tableau to provide their data, so that's my manual data access every day as I download a Tableau workbook and then export CSVs. Another problem I've been having is with data files or formats that aren't either useful or helpful. And you'll see some tweets here because I like to basically publicly shame the DHHS in North Carolina to get them to provide good data. So here's me being sad because the state is like displaying information that's useful, but you can't download it. What you can download is not useful information. Some other issues I've had is data consistency. Again, Liz brought up this issue with kind of having systems in place that allow for data, basically working with the data. This was a fun time that happened a couple of months ago where some changes were made just randomly that broke all my code. And it was basically New Hanover County, the H in Hanover had been capitalized and then turned to a small and then recapitalized. And then other issues are data quality, like when a whole bunch of new cases are basically found and then just dumped in the data and nothing is updated like the past data. So this is another time me crying about data quality. I've had a lot of successes though. I haven't published a lot on this, but I actually have been building some pretty amazing models and this massive database. I think I actually have better data than the state does at this point because they do like destructive editing, and I actually have a lot of the time series data that they don't. I have gone on TV about 20 times here in North Carolina to talk about COVID and to talk about what's been happening in the state. So that part's been really fun actually to kind of feel like what I've been working on has been getting out. And yeah, that's it for mine. Oops, stop sharing.
Thanks, Paul. That's really interesting. Rayoon, should we try and give it another shot?
I'm gonna be sharing her slides, so just give me 1 second here. And you can just let me know when you want me to advance.
Yeah, thank you. I think we can start from the second slide because everyone has so many before. Yeah, thanks a lot. Sorry for the problem. And so I will go quick through about my primary research. So this slide introduces my PhD studies, which contribute to extracting the most information from different data streams. So as we know, the currently available surveillance data, especially surveillance data in general, is sparse and uncertain. So, for example, there's many cases which could not be documented by using the surveillance data. So, which means relying on this single data stream will have limits the inference of spatial temporal diffusions of infectious diseases. So use the bird flu as, for example, I integrate the genetic sequence data and the disease surveillance data to explicitly characterize the footprints of the transmission of bird flu around the globe and in China, and try to identify the potential driving factors underlying these spatial temporal diffusions. Next slide, please. So build upon these integrated data streams, I apply different modeling approaches to investigate how models can fill the gaps in data streams and better inform the dynamics of infectious diseases. So in particular, my work established the innovative model inference framework, which could be used to infer the key epidemiological parameters, which is unobservable and which is also, well, obviously highly underestimated during the routine disease surveillance. So for example, my framework infers the fraction and contagiousness of undocumented infections of the SARS-CoV-2 and the spillover transmission risks of dengue and bird flu. Next slide, please. Yep, the next one. Yeah. So given the spatial heterogeneity, which is a topic we will talk later, and is the potential impact of spatial heterogeneity on the global elimination of passengers, my work set a global vision to design the strategic planning of different intervention plans, which propose a feasible approach to integrate the global efforts and the resources to suppress the future waves of the diseases. Yeah, that's all. Very quick about my work. So the last slide is nothing.
Great. Well, thanks, everyone. Thanks very much. That was really interesting to learn about all your individual research. You've all done such great contributions, and I'm really glad you're here. So I have a set of questions, and we have some questions from Wei and I to kind of get a conversation going. For the audience members, you're also welcome to enter questions into the chat function right here. And Wei is going to monitor the chat for questions from the audience. And in the meantime, I'll be asking you some questions that we prepared in advance. So Wei, feel free and interrupt me if questions come along. So we prepared a bunch of questions. I actually want to start with a question about scale, which is obviously one of the most fundamental geographic concepts. And a number of you sort of mentioned this in some of your presentations. But So the question I'd like to address is, what is the role of spatial and temporal scale, including global, national, community, individual, and even biological parameters, and as in different virus strains of the coronavirus, in understanding the multifaceted factors driving the spread of COVID-19 and the new variants of it? And also, at which spatial scales or which scales should non-pharmaceutical and pharmaceutical interventions such as vaccination be implemented to maximize their effectiveness? And related to this issue of scale is this idea of spatial and temporal heterogeneity that's inherent in epidemiological dynamics and intervention strategies. And how does that heterogeneity enhance or hinder the success of the response to the pandemic? I know there's a lot to chew on there, but I hope it connects with all of the things you've been talking about and the socioeconomic inequality issues and issues about trying to understand mobility and travel restrictions and so on like that. And I'll open the floor to everyone, but maybe Rayun, since you were sort of addressing some of this and we waited so long to hear you speak, I thought maybe I'd ask you to go first in responding to this question.
Well, thank you so much. So I do think that the scale, as you said, the scale is really the fundamental science topic for the GIS. But I think when the GIS applied to the infectious diseases, the most important thing we need to know is, before we decide which scale is suitable for our analysis, I think the first thing we need to acknowledge is that the disease dynamic is highly, on one scale, is highly dependent on the many other factors on the other scales. So this is kind of like scale dependency. This is the nature of scale dependency of infectious diseases. So because of this, and there is many uncertainties during our analysis. So which I think is the first thing we need to address is like quantify which scales. Maybe we need to consider multiple scales, not only one single scale. And including multiple scales in our analysis and quantify the uncertainties. If we make the cross-scale analysis, what's the uncertainties of underlying our assessments? And also maybe say we have some policy implications, and what's the uncertainties? Yeah, this is a thing. Well, maybe probably a little bit different from the question. But this is the first thing when I think come into my mind when I see the scale, and especially when the scale issue applies to the infectious diseases.
Yeah, I mean, it's interesting when you bring up the word policy, which is of course what the symposium is addressing, is that these policies are happening at all these different scales simultaneously, and the infection is happening, in a different way among individuals and so on. So it's an interesting juxtaposition. Thank you for that. So yeah, I'll open the floor. Anyone else wants to chime in?
So I've been working with the state of Ohio in a lot of our response here. So I actually in partnership with the Ohio Department of Health. So I think what happened in the United States, at least, is that the level of response, it totally depended on the state, right? So in Ohio, we have an extraordinarily decentralized health system, and the local health departments are essentially, we're basically told they were on their own to sort of respond to the pandemic, right? And so that presents a challenge because, especially back in the winter, the disease was not stopping at county borders, right? We weren't seeing hotspots that were specific to, county level patterns. This was a statewide issue, and yet there was very little coordination between the local health departments. And so, this issue of scale is extraordinarily important for policy because in the absence of a federal response, which we did not have in the first half of this pandemic, right, it got devolved to states and states were scrambling to figure out how to do it, and some of them devolved control down to local health departments, right? And so you actually saw differences in the scale at which, you know, there could be a response differ across geographies within the United States. And so I think this created a really, really big challenge in Ohio, because for us, I think the scale dependency really depended on mobility patterns and levels of spatial interaction, right? So we have areas of the state like rural Appalachia where people are not highly mobile. They're really, you know, not moving outside of their county much. And they also have very a small set of interactions. And so the spread of the disease was very, very different there, and at a very different scale than Columbus, Ohio, right? Where we have massive interaction, large populations, high population mobility out to like 10 different counties in the surrounding area. And the response needs to differ depending on those sorts of circumstances. So I think the work that Wei was doing, and I mean, sort of all this mobility type studies, that stuff's really important, right? Because we needed that information to understand how to reach populations. So I'll leave it at that, but it was a huge challenge, the scale question in the response. And it was a mess, frankly, a total mess.
Thanks, Elizabeth. Go ahead.
I was going to just say one of the things that that's part of my current work that I got to work for is actually thinking explicitly about scale and how it's embedded in herd immunity, and the idea and the concept of herd immunity, but it's really ill-defined. Like, we don't know kind of who is included in the herd, or some people say community immunity, or, you know, or who is the community. And so some of what I've been trying to do, I'm getting there slowly, is working on models and using COVID data to try to understand at what scale can we even expect to detect this, or what scale would we have to collect data to be able to actually detect it in a meaningful way. But it actually goes in with some, I also think about issues with data collection, what we have, and what is what is the actual scale of the phenomenon? You know, what is the meaningful scale that's happening in real life? But the other thing is, I keep thinking about, and I have been for this whole pandemic, is presentation. And if the state or the nation or whatever is providing maps at a county level, I think people automatically think that is some kind of scale that is meaningful for them, or that I should judge my risk or something based on where I live. And that's been I think that's been a point of contention for me as well. It's just like, you know, what is kind of a meaningful scale for people to understand what's been happening and what's digestible and things like that.
Thanks, Paul. Shangjia, did you want to weigh in?
Okay, yeah, I'd like to add something. Yeah, I think the scale question, I think, heavily depend on the demand or the need from the policymaker, or maybe the research question we are asking, and such as if we look at the country levels, I think might be maybe no need to looking at the individuals' data and the daily data, maybe not, and maybe we just need to look at the state level or provincial level data, and to have an overview of the whole pictures of the overall pictures of the for this pandemic response. Yes, in my experience, such as I have been working on the data, just aggregated data for country level, or for the city levels, and put into the model. It's quite easy to run and to get the output. But in my another study, is looking at we try to assess the response effects for different kinds of the intervention in the city, and we applied agent-based model and include the individuals' mobility data from obtained from the mobile phone data, and it's like a require huge resources to run the model and to deal with the data, to deal with the data. So I think, yeah, it's a big question, and it depends on our time and what kinds of data we need to run, and also the how timely we should provide the evidence to provide the results to the to the public or to the policymakers. So yeah, I think it's depends on the changing situations. But anyway, we try to get a more scientific, evidence-based results to support the response. And yeah, that's some of my experience. Yeah.
Thanks,
Thank
everyone. Well, it looks like we have a couple of questions from the audience.
Well, from Eric. Paul, I'm sure you have an opinion on this too. I personally think that the lowest level of geography that we can get data for is useful. I mean, for us, the county level has not been super useful because we're actually seeing, and I think this is going to be true moving forward, and it kind of gets at one of the other questions that you asked us, Jeremy, and to consider is that, what are sort of the geographically oriented challenges moving forward? So we're at a point in the pandemic now where we're going to see where there's, I think it's clear that we're not going to get rid of this disease, right? Pandora is out of the box. COVID is not going back into its little box. It's going to be with us forever, maybe, like the flu is. That's my opinion from the sort of my epi side. But what that means is that the way that we look at data and the way we surveil this process needs to change, right? It really needs to shift. We need to be focusing on hotspots. We need to be focusing on very geographically explicit, small area outbreaks that are happening, and we need to identify them quickly, and we need to quash them quickly, because that's just sort of where we're at in the pandemic. And so I think, to answer Eric's question, I actually think we really need to be doing sort of space-time detection methods at the census tract level, or even, if possible, using individual level information, which for most of us is a pipe dream, right? Because I think that it may be unstable, but we need to harness all of the statistical methodologies we have to be doing sort of real-time hotspotting. And it needs to be very local so that we can send teams out and we can do testing there, and we can really get things under control before it goes countywide or statewide or, whatever, especially with the new variants, right? Because we just don't know what else is going to come out of that box in terms of variants and virulence of those and all of that. So that's sort of my opinion on the matter. I don't know, Paul, how you feel, but I mean, I'm really worried actually about the next year that we're not going to be doing surveillance in the proper way because we don't actually have the local geography that we need.
Yeah, thanks, Elizabeth. And if I can let me just clarify to those who didn't see the chat or maybe not familiar with the U.S. Spatial units that we use. The question is about, detecting patterns in spatially aggregated data. Do we use the very smallest spatial units that we have, which, in the United States is often a census tract, which is maybe a mile across or something like that, or a half mile in an urban area, when our observations may be statistically unstable or have a lot of uncertainty to them? Or do we use larger units, which may be more, reliable, but of course are coarser? And, as Elizabeth was saying, maybe, and as Eric suggested in his question, what do we do given that we need to stay on top of the rapidly evolving situation with the spread of the disease? So I don't know if anyone else wants to weigh in on that particular issue.
I wanted to say something really quickly about this too.
Sure.
Because I had a very interesting conversation with someone about this. We were talking about response, and one of the things.
Paul, you're really breaking up. It might, maybe if you turned your video off, we might be able to hear you a little bit better. Not that we don't want to see you, but you know, just talking about audio quality here.
Sorry, things are bad on my end. I'm not sure what's happening.
Yeah, try that.
Is that better?
Yes.
So, no. Just the things that I was thinking about with this is the not just the thinking about the spatial units, but the how quickly you can get the data. Because remember, on any kind of outbreak thing, we're looking at the past, and those contacts have definitely already happened multiple days before the cases even show up in our databases. Those contacts probably happened a long time ago. And so that's been one of the things I've been thinking about, is that not just the observed data, but how to use modeling as well with that.
Yeah, that's really true. I think the timing of the data is really an issue. And actually, there's another question in the chat from Tim Trainer. Hi, Tim. It's been a long time since I've seen you. I think that was one of the things that was the biggest challenge in terms of data, and in particular sort of space-time data. So maybe not just geospatial data, but space-time data, is that, you know, if we really want to be monitoring COVID cases in real time, we needed much, much more timely data than we had, which I think Paul is alluding to. And that was a real challenge, because he's right. You know, the contacts that led to a case had occurred probably 4 or 5 days prior to when we learned about the case, if we were lucky, right? It might have even been longer than that, given how long contact tracing was taking at the height of the pandemic. So that really limited our ability to monitor. I 100% agree with that.
Yeah, thanks for addressing that question. And the other part of that question from Tim was, what geospatial data is missing? I'm not sure if you meant like at a particular time or place or something like that, but about having data at the address level, is that something, you know, in terms of vaccination and things like that, is that desirable? I mean, that brings a whole host of sort of privacy questions into the mix as well. But maybe it's an interesting question about, if we lived in an ideal world in terms of collecting data at geographic resolution, what would ideally, as analysts, what would you want to have to, you know, make the best sort of policy responses we possibly could, you know?
Yeah, may I say something on this?
Yeah, please do.
Yeah, actually for the submission data, especially when I use the mobile phone data, as it has a huge bias. It's actually not cover all the populations. So, and also in some countries, so in some regions, especially the rural and the low income populations, and they might not have have a mobile phone, even the dumb phone, and for some mobile phone data, so for some social media locations data we obtained from the smartphones, and I don't think that we have too much data from like some country in Africa. So it has some we said a missing hole in our data set. That we don't have any data on this one, but it's very important if we can narrow these kinds of data gap, or we can completely the whole pictures of the mobility across the world for these pandemic responses, or for the infectious disease modeling. All they are important to understand. Yeah. So anyway, I think it's very important to understand the biases in the data, and also the missing informations in these geospatial data sets, and it definitely needs efforts. Yeah, across the different sectors, not just the government or the research, but also maybe also need the private sectors to collaborate together to improve the data and also improve the accessibility of these kinds of data, and for better response, I think. Thank you.
Very good. Thanks, Shinjie. Anyone else want to respond? All right. Could we actually have another question? I'm just looking at the chat here from Phil Yang. And he asked, we're almost at the end of the pandemic in the U.S. We hope that seems a hopeful statement, but I hope. And it's a good question. What aspects of geographic information science could come in to help to speed up the end of the pandemic in the U.S., in developed countries, and also in developing countries? And that sort of actually sort of hits on another question that the organizers had prepared, and really that is the general question, and in a sense the symposium. What can we do in the geographic information science community to contribute to minimizing the impacts of the pandemic? And actually, maybe this is an opportunity for all of you to talk a little bit about, how geographic information science people can work together with public health people, because you're all at really, I think, at kind of the apex of what I think as like this interaction, which is, one of the reasons we invited you here. And it's just, I think it's very innovative, and I'd love to hear about that a little bit as well. So I'm open to anyone who would like to chime in on that.
Yeah, I can have a go. So, well, related to the questions, so saying something like ending the pandemic in the US or whatever, anywhere else. I think the ending of the pandemic is sort of like global elimination or something like that. So this is also, I feel, is a scale-dependent issue. So it's like, as we can see now, like some local areas, regions, or countries have already have a very successful control of the transmission, but whereas the others will not. So this local elimination or intervention of the diseases may have some problem when it comes to the global elimination or ending the pandemic on the larger global scale. So, for example, if there is still some transmission in some area, when aggregated into the larger spatial or temporal scales, there would be in some extremely low-level prevalence on these larger scales. So I think from this aspect, what the GIS can do is like we identify the heterogeneity over space and time. And so we find where we still need to make intensive control or spend more time to efforts of the surveillance or something. And we focus on these targeted regions and areas. And we let the policymakers know that they need to focus on these areas. And so by doing so, we can contribute to the elimination on larger scales. So what I mean is like we need to focus on some local scale, local regions which still have the big outbreaks, and control that one. We will move one step towards the global elimination. And regarding the related question about how could we inform the public health policy makers. Well, I feel this is really a good question, because as many of you guys can feel that when you talk or interact with public health people, it is really hard to real message, because people from different fields, even you talk about the same thing, by using different language, it's really hard to communicate. So I think one thing, because GIS is really fancy, well, to be honest, yes, we are so confident. And we can make some very simple interactive decision support tools to let them know that, okay, we visualize this transmission dynamics. We just use the slides, like putting the parameter values. They are epidemiologists. They are more have more expertise on this, and they just move the slides, giving different values, and we can show them that, okay, based on your inputs of this epidemiological parameters, show the transmission dynamics, what the trajectory is, and if you want to put more parameters controlling the interventions or the other control methods, we can also present to you the results. So I think if this is more straightforward to communicate with policymakers, yeah, and I'm confident that the GIS can do this.
So I would say that the response in the United States, yes, I realize that we have one of the higher rates of vaccination, and clearly that's related to the fact that we have a lot of vaccine available, and that's not true of many other countries. I would say that actually we have not been in the US particularly savvy about how we are bringing this pandemic to an end. We have basically, we've taken the let's just like flood the entire area approach. We haven't been targeted in any way, shape, or form. Thanks, Paul. It's putting it nicely. Yeah, we've got the like sledgehammer approach in the United States. I think that, you know, in developing countries, there's going to have to be more targeting, right? You're going to have to figure out where do you have pockets or populations of high risk, whether it's because of socioeconomic risk, health access risk, whatever, and you're going to have to be much more selective about targeting for a number of different reasons. And I think GIS is an extraordinarily useful tool for this, right? I mean, if you have layers of information on these things that you think are important for targeting different interventions, in particular vaccination in this case, then you can use that and harness that information to come up with a much more directed method for, you know, ending the pandemic, or at least getting enough of the vaccine out or getting enough of other public health interventions out. I would say we have not done that in the United States at all, really. And we're going to have to start doing that as we get to this point where we've sort of sucked up all of the people who really want to be vaccinated, who really want to partake in some of these public health interventions. And we haven't switched to that yet. So that's my take on it. It's useful. It's super important. I just don't think we've done it in the US. And maybe other countries have, but we certainly haven't.
Shang-Jia, do you want to weigh in, or Paul?
Yeah. Yeah. Actually, my background is from my educational background is medicine and epidemiology, and then I did a PhD on human geography, and I have been working for more than 7 years in China CDC. So my experience is so important of the GIS on the infectious disease, especially I think a simple way is the communication. We use a very nice tool to present the evidence, and a very nice tool to communicate with the public health practitioners, public health epidemiologists, and also the policymakers. But as I know, at least as I know, I think we still need a lot of efforts need to do this, not just for the to training the geographers who are interested on the infectious disease, but also for those the public health, especially epidemiologists. They need more knowledge of the GIS. Yes, and I think it's sometimes quite tricky. As Rin said, we need a communication. We need on the same page. We need to kind of use the similar, the both set they can understand. We need the language. Both they are easy to understand. So I have some experience on this, but we have quite a lot need to do. I would like to highlight here, and definitely GIS have a huge impact. I think we can see it in the future, not just on the infectious disease, but for all the global health problems. Yeah.
Was this about how GIS can help end, or was it about vaccination? Or sorry, I was gone for a little bit there.
Well, it was kind of an open-ended question because I keep adding questions onto the questions, but I think the original question from our audience member was, how can GI science help end the pandemic or minimize the pandemic? But then I also kind of added a bit onto that about the intersection of GI science and public health, because you're all kind of experts at that intersection, which is a challenge. So I sort of wove that in there. So.
See that, and that is that you, Phil Yang, that I know, which is an awesome question. So I'm going to go back to something that, again, Liz brought up about the ability to integrate way back when she talked in her intro about data integration. And I'm going to point at one specific thing that I'm doing right now that I think is pretty useful. Is I did finally get linked up with some people at the state and some other scholars here on campus. And we're taking ideas like, where is vaccination uptake low? Which is like one number, right? Like you look at like what proportion of people have taken the vaccine, or what proportion haven't. And we're trying to use our ability to integrate a lot of different data sources to understand who is it in those places that have decided not to be vaccinated yet, because thinking about public health interventions and about what to do to increase vaccination is going to be a lot different, in Western North Carolina than it is in the eastern part or the southern part of the state. And I'm sure where everyone else is, knowing, that people aren't homogenous and beliefs aren't homogenous, it varies. That's where I feel like I've been really able recently to kind of bring my skills as a GI scientist to something that is actionable, right? That we're trying to actually create information given, in a non-data rich environment. So.
Yeah, to me, one of the biggest challenges is really what I talked about at the beginning, is that I tip my hat to you, Paul. I was exceedingly frustrated that there was nobody that was seeming to think about, well, okay, everybody wants to use data, right? Everybody wants a model that tells, an epidemiological model that tells us when the pandemic's going to peak and all that sort of stuff. And yet the models and all of, even GIS is only as good as the data, right, that we have. And it was so clear to me that our data was just crap for a really long time, and we were trying to make inferences off of that. And this integration issue was huge, right? Is that you had, 15 different agencies collecting 15 different things that could potentially be useful, but nobody was actually thinking about how to create a system whereby it's integrated and used to create intelligence, right? Because intelligence is what we need, not data, right? We need intelligence at the end of the day. And I felt like, to this day, I'm a geographer because I feel like GI science is one of the most powerful ways that we can integrate data to produce intelligence. And there just wasn't a lot of it going on, There was not a lot of mapping. There wasn't a lot of geospatial data integration or data science within the GI science realm at the beginning of the pandemic. And I get that there's public health issues around privacy of data and all of that, but we're talking about a global pandemic, right? There's like a certain level of we need to make sure people don't die. Isn't that more important? So that was to me the greatest frustration, right? Just huge frustration. And I personally don't think it's fixed. I still think we have a massive issue where we never really figured out this data integration issue. I think the CDC is finally sort of being able to do this work again, and perhaps we'll see some improvements. But, even in my own state, it's horrendous. I also, and this is a question for the other panelists, one of the things that I saw was this sort of as Paul alluded to, this proliferation of dashboards, right? And so many of these dashboards were being done in like Tableau or Power BI and these things that weren't really meant to integrate data and create intelligence, right? They're sort of easy one-offs. And that was really frustrating because it also meant you couldn't scrape websites for data anymore because there's this proprietary backend to these tools. I don't know how you guys felt, but I felt that actually hampered things, was the proliferation of, public dashboards that didn't really integrate data well.
Totally agree with Elizabeth. And actually, this kind of question has been discussed for many years, even just in the public health surveillance. They have many surveillance systems, and it's very difficult, even in their public health centers, they are putting all the surveillance data together. So, it's very important, but I think it's uneasy to do. And I think the WHO have announced they will build like the epidemiological intelligence center, data center in Berlin, and we hope they can make some huge progress on this, to respond to the epidemics. Yeah, we hope.
Thanks. Thanks for that. Well, maybe we can do one more question. I don't want to go too past the top of the hour because it'll be an hour and a half, which is a good long time. But maybe we can just do one more question here. I'm trying to think of what I want to do, but maybe it's a good time to talk about vaccination a little bit, because this seems to be one of the most timely issues, and we really haven't talked too much about vaccination. And I do have a question about it. Global vaccination efforts have unfolded very differently across different regions. What are the geographical challenges to vaccination, whether it has to do with access to data, which we're talking a lot about, but also, there's spatial issues around logistics of the distribution, adherency to vaccination, those kinds of things that have a very strong geographic kind of expression. And what does geographic information science have to offer this global vaccination effort?
Well, I think the first thing, the thing we can do, is to identify the inequities. So something like the remoteness or the travel time to the nearest vaccination centers, and then we identify these inequities across different regions. We say, what's the access to the what is the coverage of this vaccination in different spaces, so we can help to, optimize the allocation of the vaccines across space at least. Yeah.
So I would say that there are plenty of spaces. Thinking about allocation and distribution. One of I'm coming back to time and feeling like we've been chasing things. To understand what kind of things GIS could help with. I know that for me, I was with some people in Michigan, I was getting requests about allocation and distribution and thinking that those were the bottlenecks. And I was like, you've missed those. You're like, start thinking about hesitancy. You've missed allocation distribution, because by the time you fix the allocation, you're going to be on to hesitancy anyways. I mean, I understand that wanting to get the vaccine in the right spot at the right time, but I just kept thinking, like, if you're just thinking about how the vaccine is being allocated, like, forget it. You're a month past it. Thinking about it, like, just put all your effort into like getting vaccines in arms rather than getting a vaccine into a freezer somewhere. And so that was the thing I was just thinking about. I've been thinking about is is this idea of how we can help to get the vaccines in arms and thinking about some of that.
Anyone else want to weigh in? I'm wondering, Rayan, you said spatial, optimize the distribution of the vaccine spatially. I guess, what does that mean for GI science? Like, what specifically should we be, okay, we can map areas where vaccination rates are low and say, get the vaccine there, or this country or something like that. But, there's a long, obviously, research history of spatial optimization in the GI science community. What is it we should do? Should we be trying to, should we get our spatial optimizing experts, to get to the policymakers? Should we be talking to people in Pfizer? Are there spatial optimizer experts in Pfizer and these different companies, or the policymakers? I don't even know, actually. I'm just saying my own ignorance here out loud, but I'm just thinking in terms of on the ground, what does it mean to do that,
Yeah, I do feel like even though we have the optimized strategy and we tell them like hey, we have the optimized the best option for you, but they probably don't buy it. That's true. So, I think, so instead of doing the optimization, and I do feel like this is really hard because the realistic world is really complex and optimization is more realistic, is more hypothetical. So I think like the GIS could identify the barriers in delivering these vaccines. So maybe we have let's say we have the road network data, and then we find that if we want to deliver it to some remote areas, we need to have the road, right? We don't have that one. So with these hard to reach areas, we need more times or cost too much. So we could identify these remote areas, and we can tell the health policies, like say, hey, this is areas which is hard to reach, but you should definitely need to consider these areas. I think this is more useful than we directly propose an optimized strategy and try to convince them like this is an optimized strategy. I don't think they'll buy that. Mm-hmm. Yeah. So if we identify those hard to reach areas, we can create a fancy map. At least this is very straightforward to see that, okay, they can catch up the hill. Okay, there it is. So they could make their decisions themselves.
Thanks. Well, we're close to the top of the hour here, but I don't know, Wei, if you have anything else to add, or if someone else wants to weigh in or have any final thoughts.
I think I'll really appreciate all of the panelists to give those insightful thoughts. About the last one, I can just share one experiences, because back to the Harvard Medical School, we used to collaborate with Johnson & Johnson, and also do something like it's called the dengue distribution thing. They also want to do something like based on the predictions about where that the dengue outbreaks will happen, for example, and then they can distribute the vaccines first and to those areas. So I just want to share this some experiences maybe related to the last question.
Yes, just add some comments about the vaccination. Definitely, if we have more people vaccinated, would be good, it would be better. But I was thinking, what's the impact of the vaccination on the variants, and also combined with the mobility. because for other infectious disease such as influenza, you have some kinds of like have some kinds of the pressure of the vaccination. They will have some selective pressure, and if you vaccinate these kinds of variants, and maybe other variants will be increased, the cases will be increased. So it's interesting, but we don't know for this kind of phenomena in COVID-19. But we need to closely monitor these kinds of potential, and also I think the GIS and also the mobility data and genomic data, we can combine these kinds of data and tools together to understand the future of the pandemic. Maybe we have another wave caused by another new variants. We don't know, but yeah, in this vaccination era, we still have a lot of work we need to do and close to monitor the changing situations.
Thank you. All right, any final comments from anyone else? All right, well, on behalf of Wei and myself, let me thank you, our panelists, Elizabeth, Shinjia, Rayun, and Paul. Thank you very much. This was really, really illuminating and a great kickoff for the symposium. Thanks to all of those of you who attended. On the half hour, we actually have the official welcoming session for the symposium, featuring some of our former presidents of UCGIS to talk about the history of the organization. So be sure to stick around for that. And thanks very much, everyone. Everyone be well. Bye.
Thank you very much.